Thank you, Professor Fragasso. We have some questions already from the audience, so maybe I'll start with asking you the first. One of the questions that's asked is, do you think that metabolic modulators like trimetazidine should be part of the discharge prescription for patients, so if they've had revascularization? So do you think it should be standard even if you have opened up epicardial disease?
Actually, can I answer to the first question?
Sorry?
Can I answer to the first question by Dr. Mukadam?
Oh, yeah, which is a similar thing, isn't it? Is there a role for trimetazidine in prevention? But then maybe we go on to the next.
What I would like to say is that what we can do with metabolic treatment in ischemic heart disease is that we can reduce the effects of ongoing ischemia. So if, despite the stent, despite successful revascularization, you still have ongoing ischemia, then of course, metabolic approach would be very helpful in reducing the long-term effects of ischemia. Okay, so I don't think that we should give all patients trimetazidine when we discharge them, because we should be sure that they are not developing chronic acute ischemia when provoked. But this is it depends on what you use as a prognostic stratification in these patients. As I said before, I would say that yes, we should provide complete treatment, so hemodynamic and metabolic.
Okay, great. And maybe I can answer the question that's about how do you blind patients in an interventional trial? So to give you some details, what we do in these blinded placebo-controlled trials is that the patient comes in to the cath lab. They have, as standard, the radial or ephemeral approach, and then they are listening to music via headphones, and so they have auditory isolation, so they don't know what's happening in the lab. And then we give them opiates and benzodiazepines in incremental doses until they are fast asleep. And we aim for a deep level of conscious sedation so that they're asleep but not anesthetized. And once they are asleep, we then randomize them to have stenting or nothing more done. So all of those patients have all of the steps until the point of stenting or placebo. So they have a radial angiogram or femoral angiogram, the catheters are put in, we take the pictures. If we do physiological assessment, we do that too. And then only after that point are they put to sleep and randomized. So when they leave the lab, they are asleep, so they don't know what's happened to them. And that's how they are blinded. And importantly, outside of the lab, none of the investigators or anyone who sees them, the physicians, the nurses, have any idea what's happened inside the lab. So they have no further contact with the physicians and the nurses that did the procedure. So I hope that helps.
I would like to answer the question relatively to the role of trimetazidine in atrial fibrillation. Well, actually, there is not a specific electrophysiological effect of trimetazidine, but then again, if you prevent ongoing ischemia, then of course you can also prevent atrial fibrillation. You can prevent the further development of left ventricular dilation, left atrial dilation, and therefore if you prevent ischemia, if you prevent the effects of ischemia, then of course you will also be able to prevent arrhythmias related to ischemia, and atrial fibrillation is one of those. And also, I would like to answer the question whether there is any role for trimetazidine in patients with unstable angina. Well, again, since the drug is having a real anti-ischemic effect, it's not preventing ischemia. It's just an anti-ischemic effect in the sense that it prevents the deleterious effects of ischemia. Then, of course, in patients with unstable angina would certainly benefit from the fact that despite the problem is still there, you can stand more ischemia because you will have less damage from that particular kind of ischemia, such as unstable angina. So I think, yes, it has a very important role, and it should be used also in the acute phase. But unfortunately, this is my opinion. We do not have research data relatively to this. But once you understand the mechanism of action, then of course you want to give a real anti-ischemic drug, and trimethazine is one of those.
Okay, and so the next question we have is, do you have a preference between ranolazine or trimetazidine? When do you use which one, or do you just opt for one?
That's a very good point. Well, ranolazine is a very similar drug to trimethazine. It's been shown to be a partial fatty acid oxidation inhibitors, and then after the FDA asked for a subsequent study, they found out that there was a prolongation of the QT. So they invented this new mechanism, which is the inhibition of the slow inward sodium current, which is actually, I think, is a mechanism which is after the anti-ischemic effect of the drugs. I think, for my personal opinion, trimethazine appears more well tolerated. It has less influence on renal function, and therefore I prefer trimethazine. But still, I mean, ranolazine is a similar drug, and and then it depends on the availability on different countries.
Okay, and then maybe I could take the question. Someone has asked, what's the role of the ischemia trial in angina management? So, of course, I showed you the data from the point of view of the ischemia trial on cardiovascular death and MI, and the combined endpoint in terms of prognostic endpoints, and we saw no difference between invasive and the conservative approach. In terms of angina, of course, the ischemia trial was unblinded, but what they showed was that there was some reduction in angina in the patients who had the invasive approach. And this reduction in angina seemed to be greatest in the patients who had more frequent angina to begin with, which is what you might expect. But of course, that was an unblinded trial, so it's important to remember that. And of course, I talked about how that might impact the results.
I would like to answer two questions. One is actually going back to what I was saying before. Maybe my answer was a bit confusing. Well, this colleagues is asking, how can we be sure that there is still ischemia so that we can use trimethazine? I mean, we are talking about probably ischemia which cannot always be detected by the means we use now, by, for example, myocardial perfusion scintigraphy or magnetic resonance imaging. But as we said before, we presume, and the data tell us, that probably there is ongoing ischemia, even to a subliminal level in these patients, because atherosclerosis is a systemic disease, and this is probably the reason why when you revascularize a calculate vessel, you still have problems, because there is the periphery is doing its job. So I think that when we treat these patients, once they have developed clear-cut coronary disease, and we see this because they have events or they have evidence of coronary disease, we should treat them both with hemodynamic drugs and also metabolic drugs. And the second question is, any role in heart failure? Well, yes. I mean, as I've been showing to you, I've been interested mainly in evaluating the effects of trimethazine in patients with heart failure, and the effects are very surprising, because the drug is really effective in reducing the effects of heart failure, and as we said before, probably preventing heart failure, and when heart failure is there, probably by reducing the hemodynamic impairment of heart failure. So I think, yes, should be given in patients with heart failure.
And what about peripheral arterial disease? People have asked about that too. Is there a role for trimetazine there?
Yes, I mean, there are there are some data, some pilot studies. Professor Rosano did a study on this in the past and showed that, of course, it improved peripheral vascular disease. I mean, the exercise tolerance, the interval, the free interval, working interval, because, you know, the drug is working at the level of the muscle. I mean, even the peripheral muscle can be ischemic when you have peripheral artery disease, and therefore you improve, of course, metabolic adaptation of the ischemic muscle. And this is good for the heart, but it's also good for the skeletal muscle. I must say, I mean, now just an anecdotal problem. You might remember that some athletes in the past have been excluded by the Olympics because they were using trimethazidine, because actually it made the possibility of standing, you know, greater sort of oxygen reduction when they exercise, and the muscle was sort of dealing in a better way with this reduction of oxygen availability. And in fact, the drug has been included in the WADA as is a doping drug. You know, the WADA is the Association of World Anti-Doping Association, because it's good for muscles, peripheral, and also for the heart.
Okay, fantastic.
Sorry. Yeah, another drug. I remember the tennis player Sharapova, I think, was using something like trimethazidine, but it's a different drug which is marketed in the Soviet Union and in the Russian countries, and also she was excluded from sort of match because of that.
Wow. Okay. So thank you very, very much, Professor Fragrasso. I think we're at the end of time now on our webinar, and also the end of our questions. I thank you very, very much to the audience for listening to us and participating. And maybe we leave you with the closing thoughts that hopefully there is a role for anti-anginal medication, risk reduction, and revascularization in these patients, and that you shouldn't just consider one approach. Professor Fragrasso, did you have any other closing remarks?
No, yes, I think that this was a very important meeting, because thanks especially to your work that these issues have come up again, and I think you are doing a wonderful work with your studies, which actually are showing us that we have to do something more for our patients. It's not enough to dilate arteries or to bypass them. So thank you, Rasha, for your intervention, your studies. Keep on this track. Thanks.
Thank you, Professor Fragrasso. It was fantastic to work with you. Thank you very much to the audience.
Bye-bye. Thanks.